Hello everyone and welcome. Today we are going to dive into a foundational topic in our field, the assessment of food and nutrition related history. This is the first and perhaps most critical part of understanding a client nutritional picture. It's where we gather the clues that will guide to entire nutrition care process by the end of this lecture. So you will understand the key components of person nutritional status and the various tools we use to assess what, how and why they eat. So let's get started. This lecture just consists of two main components, nutritional status and nutritional assessment, and finally we will summarize this lecture in one slide. So the nutritional status. What exactly we are trying to determine when we do an assessment? We're trying to understand the client nutritional status. This is defined as a physiological conditions of an individual's which is determined by the balance between their nutrient intake and their unique nutrient requirements. So think of it as an equations with two sides. So on the other side, in one side, we have a nutrient intake. This isn't just what a person eats, it is amount of nutrient that is actually absorbed into the body from all sources: food, drinks, medication and supplements. And also, intake is influenced by several factors: the amount of nutrient in the diet, its bioavailability based on the food source, and the body's ability to digest and absorb it. On the other side of the equations, we have nutrient requirements. So nutrient intake, and the other side, nutrient requirements. This represents the body's actual need for a nutrient, and it's unique to every single person. We estimate these needs by looking at factors like age, gender, physical activity level and life cycle stage. But we also must consider genetics, disease states or medical conditions that can significantly alter those needs. So the goal is to see if these two sides are in balance. So now let's look at the visual representation of this balance. Here, this is the balance, and this is the one side that I mentioned before, and this is the second side, nutrient intake and the nutrient requirements. So this figure illustrates the various factors influencing the balance between nutrient intake, absorption and the nutrients requirements to achieve optimal nutritional status. So the figure provides a great visual for the concept of nutritional balance. In the center here, you see the scale perfectly balanced, representing optimal nutritional status. On the left band of the scale, we have nutrient intake and absorption. This influenced by everything that goes into deciding what we eat: our preferences, knowledge, culture and religious belief, and economic access. Also, the economic access also maybe it is also affected by physiological factors like gastrointestinal functions and the health of our microbiomes, which impact absorption. On the right band, we have nutrient requirements. This side is influenced by body's demand. Factors like infections, disease, or injury increase our need for healing. Life cycle stage like growth, pregnancy, and lactation also have higher requirements, and of course, basic body maintenance is determined by our age, gender, height, weight, genetic, and stress level also. This balance is dynamic and constantly shifting. But what happens when this scale tips out of balance for a prolonged period? So the development of nutritional deficiency, nutritional imbalance developed over the time when intake is consistently higher or lower than the body's need. This process can lead to a significant changes in biochemistry, anatomy, and physiology. So the figure in the next slide shows the progression of a deficiency and the assessment component used to detect it at each stage. So in this figure, when intake inadequate or requirements are significantly increased, a nutritional deficiency can develop over time. This figure shows the typical progression and importantly how our different assessment methods can detect the problem at various stages. It starts with inadequate intake. Or absorption, increase in nutrient requirements. Initially, the body might adapt, but if the deficit continues, we see depletion of body store and tissue levels. This is a stage where food and nutrition related history can give us the first clues, and next the deficiency leads to biochemical dysfunction. So we can't see this with the naked eye, but it's detectable through biochemical data like blood test if it progresses. So we see physiological and cellular dysfunction, which might manifest as fatigue or other non-specific symptoms. Eventually, this leads to observable clinical signs and symptoms like skin changes or overt anemia, which we would identify the nutrition focused physical exam. If left and unaddressed, this can lead to morbidity and maybe ultimately mortality. So our goal as practitioners, dietitian, nutritionist, physician is to intervene as early in this process as possible. So to do that, we first need to identify who is at risk. That brings us to nutrition screening. So nutrition screening, before we can do a deep dive assessment, we need a way to efficiently identify which individuals actually need our services. This is the purpose of a nutrition screening. It's a quick, simple process used to spot the clients who currently have or are at risk for nutrition problems. So the main goal here is cost effectiveness. we want to direct our resources to the patients who will benefit most. It is important to understand that screening is technically considered to be outside of the formal nutrition care process. It is gatekeeper to the NCP or nutrition care process. From an either standpoint, screening ensures that patients in need are connected with the specialized care nutrition a professional can provide legally. It is a process by which a portion of the patient's care is formally transferred to the nutrition professional. To be effective, we should always use validated population-specific tool whenever they are available, such as malnutrition screening tool (MST) or the mini nutrition assessment (MNA). So, what makes screening tool good tool? This is good question. So, what makes screening tool a good tool? So, characteristic of an ideal nutrition screening tool. An ideal screening tool has several key characteristics. First, it must be simple, quick, and easy to use by a variety of healthcare providers, not just dietitian. It should utilize data that is readily available, like from patient's chart or simple question, and to be cost effective to administer. So beyond logistic, it must be both reliable and valid. So what is reliability? Reliability means consistency, produces consistent result. So inter-rater reliability and inter-rater. So there's inter-rater and inter-rater and inter-rater. Inter-rater reliability means different people get the same result, while intra-rater reliability means the same person gets the same result on different occasions. So this is the reliability, means consistency. While validity means accuracy, while reliability means consistency. Validity means accuracy is the tool measuring what is supposed to measure. Sensitivity is the ability to correctly identify patients who do have a nutrition problem. We don't want false negative. So this is depend on the sensitivity. And there is also a specificity. So sensitivity is the ability to correctly identify patients who do have a nutrition problem. We don't want false negative. And specificity is the ability to correctly identify patients who don't have a nutrition problem. We don't want here false positive, while in reliability we don't want false negative. So let's look at the example of widely used screening tool. The MNA, Mini Nutritional Assessment, is a validated screening tools developed for subacute and ambulatory elderly population. So this is the questionnaire of MNA. As you can see, it is very simple point-based the questionnaire. It asks about recent food intake decline, about weight loss. For example, here, has food intake declined over the past 3 months due to loss of appetite, digestive problem, chewing or swallowing? And there is answer. So we can choose one of these answer. So and the second, regarding weight loss during the last 3 months, weight loss greater than 3 kilograms. I put 0 here because these value we summation and calculated, and after this we can judge this person suffer from malnutrition or not. So it's ask about recent food intake decline, and ask about weight loss, about mobility, about recent physiological stress or acute disease, neuropsychological problem like dementia or depression, any body mass index also, or calf circumference. Each answer is assigned a point value, so you total the number and the final score place the individual into one of the three categories: malnourished, or at risk of malnutrition, or normal nutritional status. So it's a quick, non-invasive, and gives a clear result that indicate whether a full assessment is needed. And here the value that after screening, this is the score. If a patient is identified is at risk, they formally enter the nutrition care process. And for normal nutrition status, so no need, but at risk of malnutrition or malnutrition. So three categories. So now we are going to nutritional assessment topic. The NCP, or nutrition care process, is a systematic framework that we as a nutritional professional use to make a decision and provide what? And provide high quality care. This model illustrates its cyclical in nature. At the very center is the individual or population and their interaction with the nutrition professional. So the 4 steps. So NCP has 4 steps of the process surround this relationship. Step 1 is the nutritional assessment and reassessment. And here in this figure summarize all these steps. So step 1, nutrition assessment and reassessment, where we collect and analyze the data. Step 2 is a nutrition diagnosis. And step 2 is a nutrition diagnosis, where we identify and label the specific nutrition problem. Step 3 is a nutrition intervention, and step 4 nutrition monitoring and evaluation. So there is 4 steps again. Step 1 nutrition assessment and reassessment, step 2 nutrition diagnosis, step 3 nutrition intervention, step 4 nutrition monitoring and evaluation. So in this step, nutrition monitoring and evaluation, where we track a progress and determine if intervention is working. So the outer rings represent the context in which we work. This include our knowledge base, skills, evidence-based practice, critical thinking. So before we are going to illustrate or to clarify these 4 steps, we want to look for this figure, the nutrition care process, or NCP. As mentioned before, it is a systematic framework that we as a nutritional professional to use to make decision and provide high quality care. So step number 1, nutritional assessment. So let's formally define a nutritional assessment. It is a systematic methods. It is maybe for obtaining, verifying, and interpreting data needed to identify nutrition related problems, their cause and significance. The ultimate purpose is to determine whether a client has one or more nutrition related problems, which we then formally state as a nutrition diagnosis in a step. To conduct a thorough assessment, we collect data across 5 distinct domains. These are food and nutrition related history, anthropometric measurements like height, weight, and body mass index, biochemical data, medical tests and procedure which include lab work. Number 4, nutrition focusing physical finding, which involves a hands-on examination of the client. And finally, client history, which cover personal, medical, and social history. So let's now take a closer look at the primary focus of our lecture, the food and nutrition related history. The food and nutrition related history domain is incredibly broad and varied. It is not just about what a person eats, but also about the behaviors, beliefs, and access issues that shape their diet. This table gives you an overview the different subdomains we investigate. As you can see, it starts with food and nutrient intake. The what, when, and how much, but it also includes food and nutrient administration, which cover things like therapeutic diets or feeding routes. We look at the medication and supplements. Due to potential interaction, we assess the client knowledge, beliefs, and attitude towards food, as this heavily influence their choices. We examine also behavior that could be barriers or facilitator to change. We also consider factors affecting access to food like income or transportation, physical activity and functions also, and even the client perception of how nutrition intervention impact their quality of life. So we will start by focusing on the first and most data intensive subdomain, food and nutrition intake. One of the most comprehensive tools we have is food record, also known as food diary. This is a prospective methods, meaning the client records information in real time as they consume food and beverages. As you can see in this example form, it can be customized to capture not just the food eaten, but also feelings, symptoms, or activities associated with eating. The strength of food record is the detailed quantitative. Yes, detailed quantitative, not also the quantitative and the qualitative. All the quantitative and the qualitative data it provides on what was eaten, how it was prepared, and the timing and patterns of intake. To get a truly representative picture of a person typically diet while minimizing the burden on the client, studies suggest that recording of 3 to 4 days, including at least 1 weekend day, is optimal. Now, for a retrospective approach, we are going to food frequency questionnaire. This is a retrospective survey. The client is asked to think back over a specified period, like past month or like past year, or even last year, and report how often they consumed the food listed on the questionnaire. If you look at this example, you can see the format for each food item, like red meat, fish. Client checkbox ranging from daily to and gradually go to the never eat. This method is excellent for getting a long-term qualitative overview for a person's typically dietary patterns and variety. Some FFQs or food frequency questionnaires are semi-quantitative and also ask about portion size, but their quantitative accuracy can be limited. So next, let's discuss a method that combines the details of record with a retrospective nature of the questionnaire for the questionnaire. So we will start 24-hour recall. 24-hour recall is a structured interview conducted by nutrition professionals to capture all the food and beverages the client consumed in the previous 24 hours in the last day. It is a very common method used in both clinical and research setting. To improve the accuracy and help the client memory, we often use multiple pass method. On the first pass, we just get a quick list of what they ate. On the second pass, we go back through that list and ask for details, preparation method, brand names, portion size, and even what they were doing at the time. The key is to ask neutral, non-judgmental question to get the most honest report. A well-conducted recall has very low client burden and can provide data that is nearly as detailed as a food record. Each of these methods has its place, so let's compare them directly. So these methods: food record, food frequency questionnaires, 24-hour recall, and also calorie count. So in this table provide a great summary of these methods and what is the best uses for our primarily dietary assessment methods. For example, here food record gives excellent quantitative and qualitative and real-time data, but has high client burden and can cause people to change their eating habits simply because they are recording. So it's best for motivated clients where you need detailed short-term view. While in FFQ is great for a long-term big picture view of diet variety with low client burden. However, it relies heavily on memory and provide limited quantitative detail. On the other hand, 24-hour recall is quick, has low client burden, and is great for getting a snapshot of intake from client who may have limited motivations or literacy. Its main drawback is that one day may not be representative of a person's typical diet and it relies on memory. And finally, the calorie count. Calorie count involves direct observation of intake, usually in an inpatient setting. It's very accurate for what is observed but can be time consuming to analyze and may not reflect the patient's typical food preferences or intake patterns outside of the facility. So as you can see, the choice of tools depend heavily on the clinical question you are trying to answer. And now technology is changing how we approach this. So as with everything else, technology is transforming dietary assessment. We're moving beyond pen to the paper. One new area is the use of pathographic or video methods. Pathographic or video methods. Here in active capture, the individuals takes picture of their food before and after eating. In passive capture, a wearable camera might record continuously. Studies shows that these methods are very effective as a supplement to traditional tools, as they can reveal misreported or forgotten food items. More common are mobile applications, which many of you have probably used. Applications like MyFitnessPal function as digital food diaries, allowing users to track intake and activities. Yes, they can be a great tool for both client and clinician, as many allow data sharing and can save the clinician analysis time. However, it is our professional responsibility to investigate any applications we recommended to ensure its food database and calculations are accurate and valid. Once we have collected this data, the next step is the interpretation of these data. So after collecting data, our analysis usually begins with energy we need to assess the client's energy balance by comparing their reported calorie intake to their estimated energy need. This is the fundamental. So next, we look at the balance of food group in the diet. Are they eating enough of fruits? Are they eat enough of vegetables? Are their grain mostly whole grains? To evaluate this, we compare their intake to established quantitative food patterns, which are essentially a blueprint for a healthy diet at various calorie level. So example, you might be familiar with includes the USDA My Plate or Dash Diet Better or the Diabetes Exchange list. From food groups, we can drill down even further to specific nutrient. So to evaluate the adequacy of the client macronutrient or micronutrient intake, we compare their consumption data to a set of standard known as dietary reference intake or DRI. It is crucial to understand what these different value means. So the RDA or recommended dietary allowance is the value that meets the needs about 97% to 98% of healthy individuals in a specific group. If a person intake is at or above the RDA, likely adequate. While adequate intake AI is used when there isn't enough scientific evidence to establish an RDA. It is based on observed intake in a healthy population. While UL, tolerable upper intake level, is the highest daily intake that is unlikely to cause adverse health effect. This is our safety and it is especially important when looking at fortified foods and supplement use. The AMDR, abbreviation of acceptable macronutrient distribution range, provide range for carbohydrates, protein and fats expressed as percentage of the total calorie that are associated with reduced risk of the chronic disease. So let's see what the output of this analysis looks like. Example here of a nutrient analysis report. Data analysis software can provide detailed breakdown of the client intake of calories, macronutrient, vitamins, and minerals, which can then be compared to recommended value. Here the analysis report from after using the software analysis. This is a typical nutrient analysis report generated by dietary assessment software. It takes the food record or 24-hour recall data and translate it into hard numbers for dose and nutrient. You can see it organized into sections like basic components of calories, what is calories, and fat, protein. So calories, fat, protein, vitamins and minerals. For each nutrient there are 3 case column values. Here is the client of actual intake of the diet, and RCMD is the recommended amount based on the data reference intake for that person, age and gender. And the most useful column is often a percentage of RCMD, which instantly shows you whether the intake is adequate, deficient or excessive. For example, we can quickly see this person iron intake. The iron intake here, the iron intake is only 50% of the recommended, while their vitamin B2 here, the vitamin B2 riboflavin is over 200%. So the field of nutrition is constantly evolving, and one of the exciting new areas is the study of bioactive compounds. These are defined as compounds in food that can interact with our living tissues and produce a biological effect. This can be either a positive or a negative effect. So in this table, give just few examples: beneficial or harmful. Beneficial compounds include things like curcumin from turmeric, which has anti-inflammatory properties, or phytosterols from whole grain and nuts, which can help lower low density lipoprotein LDL cholesterol. On the other hand, there are harmful compounds that can enter our body supply, such as heavy metals like mercury in certain large fish, or lead from contaminated water pipes, which are neurotoxins. It is important to be aware of these, but you should know that our ability to quantitatively assess them in a diet is still very limited, as are the standards for safe or optimal intake levels. So now let's broaden our view again and look at the other domain for the nutrition related history. So the other K of history domain, as we saw in the overview, a complete history covers more than just food intake. So let's briefly touch on these other crucial areas. Food and Nutrient Administration looks as how of eating. This includes current diet orders in hospital, any therapeutic diet they tried in the past, food allergies or restrictions, and the overall eating environment. Knowledge, belief, and attitudes is about what going on in the client head. Do they have the cooking skills to implement a new diet? Do they have religious or cultural beliefs that will impact food choices? Are they struggling with emotional eating? This information is key to developing an intervention they will actually follow. Behaviors are the actions that result from those beliefs. We assess for things that might be barriers like restrictive eating, binging, or refusal to eat certain food, and we also assess adherence to previously recommended plans. And finally, we must get a medication and supplements. This is because of high potential for food drugs interaction, where food or supplements can alter drugs effectiveness, or drugs can alter nutrient absorption or metabolism. So now let's continue with the final few domain. Moving on, we also need to assess a client life context. Nutrition access explores the social determinants on health. Can the client actually obtain safe and nutritious food? We ask about things like access to grocery stores, the availability of meal preparation facilities, and their participation in food assistance programs. You can have the best diet plan in the world, but it's useless if the client can't access the food. Physical and functional is also key. We assess their general physical activity pattern, as this is the major determinants of energy need. We also look at the physical functioning related to nutrition, like their ability to feed themselves independently, or for a new mother, their ability to breastfeed. And finally, and this is often overlooked, we must consider nutrition quality of life. We need to be sensitive to the impact our recommendation will have on the client lifestyle, the cost, time, effort, and loss of freedom. An intervention that drastically reduces a person's quality of life is unlikely to be sustainable. So, when we put all this information together, what are red flags we're looking for? This slide summarizes many of the key nutritional risk factors we might uncover during the comprehensive assessment, organized by the 5 assessment domains. So under nutrition history, red flags include obviously inadequate intake, excessive alcohol use, disorder eating beliefs, or limited access to food. For anthropometric measurements, we are looking for things like significant unintentional weight loss or signs of muscle wasting. With biochemical data, we look for abnormal laboratory like anemia or poor lipid profile. For physical findings that are concerning include poor appetite, digestive issues, or non-healing wounds like pressure ulcers. And the client history risk factor include things like being very young or elderly, having chronic disease like diabetes or cancer, or facing socioeconomic limitations, and high stress level. Finding any of these should prompt you to dig deeper. So let's wrap up with our key takeaway for today. So the summary of this lecture, to conclude, let's review the main point first. Remember that nutritional status is a dynamic balance between what person takes in and what their body uniquely requires. So nutrition screening is our essential first step to efficiently identify those who need a full workup. When the client is identified as at risk, we perform comprehensive nutrition assessment, which is the first step on the nutrition care process and our systematic process for gathering clues. The food and nutrition related history is an incredibly deep and multi-faceted domain that forms the core of this assessment. And finally, we have a variety of tools at our disposal to assess data intake. A critical skill you will develop is learning to choose the right tool for the right situation. So understanding the strength and weakness for each. So thank you. That concludes our lecture on the assessment of food and nutrition related history. Goodbye.